Aloha! This CME activity is jointly provided by the Queens Medical Center and UH-JAVSOM Department of Geriatric Medicine. We offer free continuing education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. You can now check on your CME credits online. Go to www.queens.org and type CME in the search tool. Click on My CME Transcript, then sign in to generate your transcript. About ECHO, we want to remind everyone that this is an ECHO webinar, which means that the session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during this ECHO session. Good nutrition is key to a healthy lifestyle. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open up the time for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to today's topic lecture. We only ask that you keep it HIPAA compliant case for discussion. That means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Juanette Gaylord, President of Alliance of Residential Care Administrators, ARCA. We have Maribel Tan, President of Foster Family Homes Association, Elsa Talavera, President and CEO of All Island Case Management Corporation, Kira McCoy, Health Coordinator Lead at Aloha Care, Leila Ventar, Health Coordination Manager from United Healthcare, Kauai County, and Dr. Rita Bell Fernandez from University of Hawaii.
Yes, please.
We are in the third month of our series on mobility. If you're interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. The title of today's webinar is Living Well with Parkinson's Disease. It gives me great pleasure to introduce our speaker, Mr. Glenn Higa. Glenn is a fitness therapist and certified personal trainer. He offers in-person and online personal training for persons living with Parkinson's disease. He is the owner of Make It Happen Personal Training. Glenn has served as the president of Hawaii Parkinson's Association, where his leadership led to fundraising, public education, and policy. He received his Bachelor of Arts in Public Relations Journalism at the University of Hawaii. Thank you, Glenn, for sharing your knowledge and wisdom with us. Welcome and aloha.
Aloha. Thank you for the opportunity to talk about Parkinson's disease and living with it. Good afternoon. My name is Glenn Higa. I'm the president of the Hawaii Parkinson Association. And as Waynette told you, and also I'm also a certified personal trainer. So let me go ahead and share my screen here.
Irene, you have a question. You raise your hand, Irene.
Okay, can everybody see the slides up on the screen? All right, great. Thank you. Okay. So, what is Parkinson's disease? So Parkinson's disease is a progressive neurodegenerative disorder affecting the dopamine-producing neurons. Parkinson's is generally clinically diagnosed by a neurologist with an emphasis on identifying symptoms such as tremors, bradykinesia, and muscle rigidity. Therapies and treatment include medication, exercise and lifestyle changes. A primary risk factor for Parkinson's is age, with the average age of onset being 60 years old. Other factors include genetics and environmental factors. And unfortunately, right now, there is no cure for Parkinson's. However, therapies such as medication and exercise can reduce symptoms and improve quality of life and allow for activities of daily living. So what are the symptoms? So potential early warning symptoms include restless leg syndrome, loss of sense of smell, constipation, drooling, and masked face. Motor symptoms include tremors, rigidity, bradykinesia, micrographia, which is small handwriting, swallowing issues, postural instability, and facial masking. What most people don't know is that there are also a lot of non-motor symptoms associated with Parkinson's, and these include physical and mental fatigue, insomnia, depression, anxiety, apathy, hallucinations, and loss of sense of smell. There are over 40 motor and non-motor symptoms that are attached to Parkinson's. So who has Parkinson's? Well, in Hawaii, there are an estimated 8,000 people that have Parkinson's here in Hawaii. That number is projected to double by 2030, and that's from the Queens Medical Center, Parkinson's and Movement Disorder Center. So in just 5 years, they're projecting there will be 16,000 people in Hawaii with Parkinson's. Nationwide, there are 1 million people who have Parkinson's. That number is expected to increase to 1.2 million by 2030. 90,000 people each year are diagnosed with Parkinson's, and that's up 50% in the last 10 years. And someone is diagnosed with Parkinson's every 6 minutes in the United States. Parkinson's is more common in men than women. It is also the most common motor brain disease. Worldwide, 1% of all adults over the age of 60 have Parkinson's. So it's considered a pandemic now. And Parkinson's is now considered the fastest growing neurological condition in the world. So what causes Parkinson's? Well, the only confirmed causes of Parkinson's disease is genetics. And there are about 10 to 15% of diagnosed cases that are attributed to genetics. Factors associated with Parkinson's include, but are not proven, include exposure to pesticides, chemicals, tainted water, even where you live. So there are areas in the United States, for example, that have higher concentrations of Parkinson's, such as rural Pennsylvania, the Southeast, Los Angeles, and in the Central Valley of California. In some cases, have also been linked to head trauma, head injuries, including combat veterans that suffered concussions from roadside bombs or IEDs, boxers and MMA fighters, and football players, just to name a few. So the good news is that there are a lot of medications available to help people with Parkinson's. So levodopa is the most prescribed medication for Parkinson's. Comes in different formulations, including immediate release, extended release, oral dissolving tablets or ODTs, and continuous enteral solution, which is like a pump, just to name a few. Levodopa works by increasing the amount of available dopamine in the brain. Not everyone can tolerate levodopa and need other types of medication, such as dopamine agonists. Dopamine agonists mimic the effects of dopamine in the brain, and common examples of these are pramipexole, ropinirole, and rotigotine, which is also known as Nupro, which is a patch. Other types of medications include MAO-B inhibitors such as rasagiline, COMT inhibitors such as entacapone, and NMDA receptor agonists such as amantadine, which actually started out as an anti-influenza drug. However, these medications do not come without a host of side effects, potential side effects. Excuse me. Levodopa has some side effects, most notably orthostatic hypotension, which is low blood pressure, dyskinesia, which is uncontrollable movements, and nausea. Side effects from dopamine agonists are some of the most severe of all the side effects from medication, include impulse control disorders such as gambling, hypersexuality, and compulsive shopping. Fatigue, sudden sleep attacks, and cognitive impairment are also potential side effects. Other medications have the following side effects: insomnia, dry mouth, blurred vision, and heartburn. So for Parkinson's, there are other treatment options available besides medication, and we'll go through each of these ones, but we'll talk more in depth later about exercise because that is the must do for everyone with Parkinson's. As you can tell, as I mentioned, I'm a personal trainer for people with Parkinson's, and so I'm a firm believer in exercise because it's the only therapy proven to slow or even delay the progression of Parkinson's. And they've done clinical trials on this, and they've shown that doing high intensity interval training, getting your heart rate up, has been proven to slow down or even delay the progression of Parkinson's, and it also increases the natural dopamine in your brain. They've done brain scans with this. Beneficial exercise comes in many forms, and the Parkinson Foundation recommends different modes of exercise, including walking, jogging, high intensity training, strength training, yoga, and Tai Chi. So however you or your clients do it, my advice is the best exercise is one you enjoy and would do daily. Another therapy that is very important is social interaction. Parkinson's can be a lonely and isolating condition. So staying socially active is very important. Some ways to accomplish this is to join a support group, participate in a group exercise class, engage with others who have or don't have Parkinson's. Speech therapy is also very beneficial for people with Parkinson's, as pneumonia and asphyxiation are some of the leading causes of death in people with Parkinson's. Soft and low voice are also common symptoms of Parkinson's, so speech and language therapy is also very important. Finally, there are some invasive and non-invasive medical procedures available. Deep brain stimulation, or DBS, is probably the most widely used. Involves two electrode leads implanted in the brain and attached to a pacemaker-like device to regulate motor symptoms. Focused ultrasound has recently been approved for use of reducing motor symptoms as well, and that involves ablation of the parts of the brain that cause the tremors. Finally, there is enteral suspension, which is known in the market as Duopa. It is similar to an insulin pump as it delivers the levodopa directly to the bloodstream. And there is a next generation pump that just entered the market known as Vialis. Okay, so that's Parkinson's. Okay, so a little bit more about me. My journey of a lifetime. How did I get here? I was born and raised and still live in Kalihi. I'm a local boy, a brother, and fortunately, I'm at the age where I've been called uncle a lot. Together with my girlfriend Edie, we have raised our twin stepdaughters, or my twin daughters, Tani and Tori. Tani is an officer in the Hawaii Army National Guard, and Tori is a veterinarian currently doing a residency at the University of Florida. That's Tani at the top, and that's Tori on the bottom. I was a sales executive in advertising and sports marketing and spent over 20 years in profession before I was diagnosed with young onset Parkinson's disease 7 years ago at the age of 48. Started working with a personal trainer a year after diagnosis, and did wonders for me. He encouraged me to become a personal trainer myself and work with people with Parkinson's. So I thought if it helped me so much, I should help others too. So at age 51, switched careers, got certified as a personal trainer. Still to this day, I don't know how I did it, but I got certified as a personal trainer, and also as a Parkinson Wellness Recovery Power Move certified instructor the following year. I started volunteering with the Hawaii Parkinson Association about 8 months after being diagnosed. And in 2023, I was elected president of HPA, and this past April, I was elected to my second and final 2-year term. So, how do I live well, smile, and live my best life with Parkinson's? So here are the key factors. The 3 things that I need to do. I need to be on the right medication plan. This means I need to be open and honest with my neurologist, not only what my goals are, but what are my activities of daily life. It also means I need to know how my body is really feeling. Your physical and mental state affects the performance of the medication, and I know my body well enough that I can feel when the medications are starting to wear off, or when I have too much medication in my body, because both can affect your body equally well. Really, the way to describe medication is that it's kind of like Goldilocks. Okay, not too little, not too much, but just right. Okay, so that's the best way to explain it. So this is my daily medication regimen. If it looks like a lot, well, it is. Okay, because levodopa doesn't have a very long half-life. But it's a little less than I took over a year ago, so that's good. I managed to reduce my medication over time. And so yeah, it's also confusing, so here's an explanation. Okay. So every morning when I wake up, I'm usually depleted of dopamine, but because my body is rested, I actually feel pretty good. But it doesn't last very long, so I need a boost in medication to get me started throughout the day. So I'll start with half a tablet of controlled release levodopa, carbidopa levodopa. I used to take it at the same time as my first regular dose, but it was too much dopamine and I was getting dyskinesia, or uncontrollable movements. So I adjusted it to 30 minutes after taking my morning dose, and in which I'll take 1.5 carbidopa levodopa pills, and then also take citicoline, a capsule, which improves the efficacy of the levodopa by as much as 40%. Most days I take So most days I'll take 1.5 tablets of carbidopa levodopa unless I have a softball game in the morning, and then I'll save it till just before my game. I also take an amantadine, which is designed to control dyskinesia. And I usually take that in the morning and afternoon. It usually lasts anywhere between 2.5 to as much as 4 hours in between doses. I'll take 4 doses throughout the day of one entacapone and one carbidopa levodopa. I also take a second citicoline capsule during the day, one entacapone with every levodopa dose, and a second amantadine as my third dose. Evenings, I'll take a half a pill unless I have an event, and then I'll take a full pill unless there is a nighttime event. Then I'll adjust my meds. If I can, I'll skip the 6 regular dose as well. So if I don't have anything at night, like if I'm just staying home and having dinner, then sometimes I'll skip my last dose if I can. Finally, I'll cap off the night with an evening dose of extended release tablet, and that's to help me sleep, help to control the tremors when I sleep. And as you can see, I take a number of supplements as well. Fish oil, which is for joint health, magnesium, which is also for helping with bowel movements, astaxanthin, which helps brain and joints, turmeric, which helps with cell reproduction, vitamin E, super B complex, citicoline, and also take a vitamin C packet with like emergency. Reason for that is because vitamin C has been shown to improve the efficacy of carbidopa levodopa by as much as 20%. And it also keeps me healthy. So remember I talked about exercise being very important, right? So I try to work out myself 5 times a week minimum. Sometimes I get more done. Sometimes I get less, just depending on my schedule. So I really focus on the following modalities or types of exercise. Focus on strength training, high intensity interval training or HIIT. I do a lot of workouts when I work, and I also play softball. So my job as a personal trainer allows me the time to work out at work or work out with my clients as needed. And I'll play softball 2 days a week if possible. So here are a few bits of advice for people starting out in their fitness journey. If your clients are new to fitness, which most people are, here's some tips. Move big and move fast. Okay, move with intent. That means that instead of just reaching up like this, you move with intensity. Okay, repeat, but learn something new. And it's never too soon, and it's never too late to begin exercising. Okay. So positive attitude. No matter what condition you're faced with, a positive attitude is key to living well when it comes to Parkinson's. I believe that if you are not on the right medication plan or you don't exercise, you probably won't feel good. And it's tough to have a positive attitude if you don't feel good. So this doesn't happen without the other two. Okay, so if you have clients that have Parkinson's, make sure they're on the right medication plan, make sure to get some exercise, and then that will help them become have a positive attitude, which is everything. The key to living with a chronic condition. So I get asked this question a lot. What keeps you smiling while living with such a what can be a cruel condition? Cruel condition. So I found meaning and purpose. Aside from a cousin who just got diagnosed with Parkinson's, no one in my family has ever been diagnosed with Parkinson's. So then eliminates the genetic part. No one in my family has ever been diagnosed. I wasn't exposed to pesticides or chemicals. No head trauma either. So I have no idea why I got diagnosed with Parkinson's. But I truly think I was diagnosed to help other people dealing with the same condition to let them know that you can live their best life. I found my purpose in life. I'm using what could have been a tragic situation into a productive and meaningful life. It's not without its challenges, but in the big picture, it's been worth it. I stay true to myself. I'm still a local boy from Kalihi. I like to play softball on the weekends and hang out with the guys and drink a few beers. Go to UH games. I travel, and even though I have Parkinson's, Parkinson's doesn't have me. But there are times when you need to fake it till you make it, and that's when you need to live like you're in control. Okay, so if you remember my daily medication profile, you saw how many pills I take a day and the time frame I take it in. So clearly I'm not in full control, but I don't live like I'm not. I live like I am in control. So finally, just to wrap up my talk, I wanted to share a couple of videos from last year. So in January of last year, I participated in the Los Angeles Dodgers adult baseball camp. I played 10 baseball games in 5 days with Parkinson's, and no one knew until halfway through the camp when I kind of told everybody. First video is a compilation of still shots, and it was taken in my second at bat in the first game. So let's take a look.
Ano ito?
So if I didn't jump over him, if I didn't stick the landing, if I had been injured and not been able to continue playing, life would be very much different now. I'm very thankful for being very agile and having good balance. So and yes, that is me jumping over the guy. Okay, the next video is from the All-Star game at the Dodger camp. Played in a Major League Baseball spring training stadium that hosts 12,000 people, the largest in Arizona. They announced my name on the PA system, played under the lights and on the same field as Major League Baseball players play. A dream come true for sure, but watch what happens in this video. That's not, now that's, I just watch what happens in the video. So to play that game was amazing, and to get a hit in that game was also a memory that I will never forget. So I just want to wrap it up by talking a little bit about Hawaii Parkinson Association. We are an all-volunteer nonprofit organization serving all islands in the state of Hawaii. We have a resource center in the St. Francis Healthcare Liliha campus. We host 15 support groups on 4 islands who provide grants to exercise professionals who work with people with Parkinson's. We host the largest free educational symposium for Parkinson's in Hawaii, and we participate in educational and outreach active events statewide. Finally, we hold an annual fundraising walk, which will be on November 1st at Magic Island, and 100% of all funds raised stay in Hawaii. Our mission is to positively impact the lives of those affected by Parkinson's through support, education, programs, and other services. I just want to thank you for the opportunity to inform you about Parkinson's and to share my story of living well with Parkinson's. Thank you to the John A. Burns School of Medicine and Department of Geriatric Medicine. And thank you to everybody involved for inviting me today. Thank you.
Wow, Glenn, that is amazing. We are so inspired by your story. This is just awesome what you have done to help others, and your advocacy for Parkinson's and leading your best life and a purpose-driven life. This is simply amazing. And I'm so glad we could bring you here on our echo to the care home and foster home operators. So we have some questions in our chat. We have Josephine Lisa is asking about sleep attacks. Could you explain what is sleep attacks, please, Glenn?
Yeah, absolutely. So sleep attacks are basically it's when you suddenly fall asleep like that. So these are common symptoms from medication, especially dopamine agonists. Most people with Parkinson's have like a full tank of gas in the beginning of the day, where they're very alert and they're very much attentive and everything. And as the day goes along, the gas tank goes down towards empty. But once in a while, there are people who have sudden sleep attacks. So basically, what that is that they just fall asleep without warning. Okay, so especially this can be dangerous, especially if they're driving. Okay, so because you can still drive with Parkinson's up to a point, but if you get a sudden sleep attack and it's almost happened to me a couple of times where I've been driving and I kind of doze off like right in the middle of the day, and it's like, whoa, I kind of wake myself up. So those that's what sleep attacks are.
Thank you, Glenn, for explaining sleep attack. We have a lot of persons in care homes and foster homes, with advanced Parkinson's. They are residing in our care homes and foster homes. So your education to the operators is so important. We have another question. Can you explain restless legs? What can a care home operator or a foster home operator do for if their client has restless legs?
Okay, so there are a couple of different therapies that's available for restless leg. One is medication. So you can either take a Parkinson medication like carbidopa levodopa or an extended release carbidopa levodopa or something like Rytari, which is an extended release pill as well. A couple other therapies that I've heard of is there's also some other medication that's specific for restless leg syndrome. Starts with a D, and I can't think of the name right now, but it'll come to me. There's also some theories that putting light weights on their ankles will help people with restless leg syndrome, because the weights will kind of hold the legs down a little bit. And you don't want to put too heavy of weights because then they can't move, but you want to be able to move a little bit. But putting like a pound and a half to maybe a 2 pound weight around the ankles. Some people say that works for them. I tried it and I just felt like I was like tied to the bed. So that didn't work out for me too well. But I've heard of people that it's worked for them.
Thank you, Glenn, for sharing that. Could you tell us if they use the weighted on the legs for the restless leg, would that be considered a restraint? Because there is a lot of regulations for care homes and foster homes. So would that weighting be considered a restraint?
That I'm not sure of. Yeah, if that would be considered restraint. I haven't come across that um that I haven't come across that question before. So I wouldn't be able to answer that.
Mary Beth, I would add as a professor at UH and a doctor that it's always the intention. What is your intention? And if the intention is to help these restless legs and to help the person, be more comfortable, that would not then be considered a restraint. And people have weighted socks, they have weighted blankets also. So there are other ways of giving that weighted feeling. And it would not be looked at by a MedQuest as a restraint. Now we have some more questions for you, Glenn. There is Aga has a patient with Parkinson's and he has sleep attacks after meals. Does that mean he needs to increase his medications?
Um, sleep, sleep sleep attacks after meals are it's very common. So basically, what happens with Parkinson's is that a lot of people get sleepy after a meal, right? Even if you don't have Parkinson's. So it's fairly common because what happens is that protein especially interferes with the delivery of the medication. So my suggestion would be, as a person with Parkinson's, is to time your medication when you take it, so that it doesn't interfere as much with with your um with your meals. Okay, so the golden rule for carbidopa levodopa is that you take medication 30 minutes before or 30 minutes after your meal. So I would try that first, adjusted medication, and then before thinking about increasing the medication.
Okay,
Yeah.
thank you, Glenn, for suggesting the timing. The timing of the medicine is very important. So, Aga, you can try the timing. And my suggestion also is for people who feel sleepy after meals, try to make the meal less carbohydrates and more protein. If you decrease the glycemic load, if you put less rice, less bread, and have it more healthy carbs like vegetables, taro, those kind of carbohydrates will cause less sleepiness after meals and increase the protein. Now we have another question for you, Glenn. Does patients need to take blood tests if they know that they're getting adequate level of medications? Can you address about blood tests in Parkinson's disease, please?
Sure. So there is no blood test that determines your level of Parkinson's or determines how much medication you need. Basically it has to be an open and honest conversation with your neurologist to say, okay, so and what some people do is they track it either like on manually, like on a spreadsheet, or they use a symptom tracker app on their phone, on their smartphone, and from there they can determine with your neurologist how much medication you need. So it's really a gut feel by the neurologist, to be honest with you, and it's like a trial and error kind of thing. So the way we described it is, imagine you're on the freeway, and every car is a person with Parkinson's, and some cars need to go to Waianae, some cars need to go to Pearl City, some need to just go to town. And so if you're a doctor, so if you're a mechanic, you need to figure out how much gas to put into the car to get you to Waianae, get you to Pearl City, get you to town. That's basically what neurologists have to do for people with Parkinson's. How much medication do I need to give you to get you through the day?
Okay, thank you, Glenn. So what Glenn is saying is that the medication, they look at the clinical symptoms to decide the medication level. It's not blood tests. And it's different from, like, say you on digoxin, you need blood tests. If you're on thyroid medicine, you need blood tests. If you're on some psychiatric medicine or lithium, you need blood tests. But for the Parkinson's, there is no checking the level of those medications. Now, thank you, Glenn. We have a lovely question here. People would love to know about the timings and places of the support group. Can you share more about the support groups, please?
Yes, so support groups are in person and online. We have a few that are online. There are two on the Big Island. There's one in Maui, two on Kauai. One is for caregivers and one is for people with Parkinson's, and then the rest are, and then there's about 8 to 10 here on Oahu. Best place to find out when there's a support group, where is the support group located, and what times that they're being held is to go onto our website, parkinsonshawaii.org, and click on support groups, and you'll find a whole roster of support groups there. I will say this about support groups. I consider them our first line of defense against Parkinson's because, like I mentioned, Parkinson's can be a very socially lonely and isolating condition. Getting to know other people with Parkinson's can change an outlook of people tremendously. So I'll give you an example. Um, there's a person who had been diagnosed for 5 years, didn't know anybody that had Parkinson's, not a single person. And so she saw an article in midweek, saw that we had a resource center. She called me up. I was volunteering here at the resource center, and then and so she came to talk to me, and I was the first person she ever met with Parkinson's, and she was crying the whole time. She was just so happy that she finally met somebody with Parkinson's, someone she could relate to, someone that she had something in common with. So since then, and this is about 4 years ago, not only is she part of three support groups, she's also volunteers with us for Hawaii Parkinson Association. She's a mentor for other people with Parkinson's, and she's doing great. She just recently retired, and she's doing great. So those are the reasons why it's very important for people with Parkinson's not to isolate themselves because it can be very isolating and very lonely. Oh, and gabapentin is the medication for restless leg syndrome that some people prescribe.
Okay, thank you. Thank you for suggesting that. And we have a very good suggestion from Lila Vintar, who is our nurse at United Healthcare. Lila is suggesting that when you do any of these, please get an order in writing. That's a good one. Get an order in writing from the doctor and make sure it's in the care plan. So if you use the weights for the restless leg or some heavier socks or weighted blankets, at least it is documented. Documentation is very important when you're in care home and foster homes. Now we have a question. The restless leg, Glenn, would that weights on the ankle be considered a fall risk? Like, when would you suggest the weights on the legs? Would it be in bed at night? Or what is your recommendation?
Yeah, exactly. Just in bed at night, not anytime, and only when needed.
Okay, as needed and in bed. So
Yeah.
it would not, then they wouldn't be walking around.
No.
There's a question from Michelle. What's the difference between Lewy body dementia and Parkinson's disease?
Okay, great question. So there Lewy body dementia is considered in a class called Parkinsonism, which is basically the umbrella condition for Parkinson's disease, Lewy body dementia, multiple system atrophy, parasupernuclear palsy, and one other one. But Lewy body dementia is not a is not respond to dopamine therapy. In other words, that if you have Lewy body dementia, you take levodopa, it's not going to help you. Okay? So only Parkinson's is the only one. Parkinson's disease is the only one that is treatable with dopamine therapy. Okay, so Lewy body dementia is like Parkinson's, but it doesn't respond to dopamine treatments.
Thank you for that wonderful explanation. There is another question about connection. What is the relation between Parkinson's and MSA?
Okay, so I'm assuming MSA is multiple system atrophy. So same thing. Okay, it falls under Parkinsonism. Again, it doesn't respond to dopamine therapy, dopamine treatments. And so I'm not sure if there are any medications for MSA. I do know that exercise has been shown to be beneficial for just about everything, really. And I used to work with a client that had parasupranuclear palsy or PSP. And that's the one I'm most familiar with in terms of the other what you call it, the other Parkinsonisms. I do have a client that has Lewy body dementia as well. I will say this, that the rate of onset or the rate of progression is fast. It's a lot faster than Parkinson's. So that's the one thing. And also because it doesn't respond to dopamine treatment, it's very frustrating because there's really nothing that people can do with it for it right now. Unfortunately. So the decline and the progression is fast, especially as you get older.
Okay, thank you for sharing that, Glenn. For care home operators and foster home operators, what clinical symptoms should they be reporting to the doctor? Because many of them have patients with Parkinson's disease. So which symptoms to report?
Well, like I mentioned in my talk, there are over 40 symptoms that are associated with Parkinson's. The most common ones are tremors, obviously, right? Because everyone sees people with tremors, but not everyone has tremors. Okay, and this is where Parkinson's gets really difficult because a lot of the symptoms just mimic aging. Okay, so it's hard to determine which is aging and which is Parkinson's. Okay, so the three things that usually get identified as Parkinson's related are rigidity, which is stiff muscles, or stiffness in joints, bradykinesia, which is slow movements, and tremors. Okay, so those are the three things that most neurologists look for when they make a Parkinson diagnosis. But constipation is another one that is a early warning sign. Loss of sense of smell, okay, is another one that's also an early warning sign. Tremors, as I mentioned, masked face. So a lot of people with Parkinson's don't have facial expressions. So they kind of just when you talk to them, they look like they're disinterested in what you're saying, and really they're not disinterested. They just can't move their facial muscles very well. And micrographia, which is small handwriting, that's another sign as well.
Thank you, Glenn. As a geriatrician in geriatrics, if I have patients with Parkinson's disease, what I would like reported to me is if they fall. So if your patient falls, bring it to the doctor's attention. Another thing that I would like reported to me is patients with Parkinson's, they're at higher risk for depression. So if you feel your client is now looking unmotivated, they're sleepy, they may look sad, they're not eating much, or they're eating too much, or they're sleeping all the time. If you feel maybe there's a change, maybe there's a person is depressed, bring that to the doctor's attention so people can be treated with depression medicines like an antidepressant. So that's what you could report. And you play a very important role as a care home operator and foster home operator. We have some other questions, Glenn. What can this Hawaii Parkinson's Association do for people who have loved ones with Parkinson's? How can the association help?
So we have uh, a support group for care partners, caregivers that they can join. It's virtual, so it's easy to join on that one. It's nighttime at 8 o'clock p.m. It's once a month. I think it's Thursdays, and I can't remember, but go to our website and you can find it. You can find it listed on our website. It's hosted by Pat Bemis, who was a caregiver for her husband for over 30 years, and it's a really good one. They can come to our resource center here at St. Francis and the Viviha campus, and we have resources here they can access, whether it's printed materials or using a computer to find links and so forth, or just if they want to talk to somebody here, one of our volunteers, or even me, they can set up an appointment to talk to somebody here about support and resources available.
Thank you, Glenn. That's very helpful. And amazing. Hawaii Parkinson's Association is helping so many people. Thank you for having your volunteers and willing to meet with families and caregivers. There is another question in the chat. Is there anything for temperature control if somebody is getting too hot?
Yeah, this one is personal for me because I go through that too, especially at night when I sleep. So unfortunately, there's not really much you can do for that. I know that there are some people that had a wearable on their wrist that kind of helped to control temperature. And I've seen it, but I haven't inquired about it. Um, but I would say talk to the neurologist about it, and maybe your neurologist has better advice than I can give. But yeah, temperature control is also one of the symptoms of, or lack of temperature control is one of the symptoms of Parkinson's.
Thank you, Glenn, for sharing that. John, if you can help us and bring up our evaluation questions, and John, if you could also type in the chat the website so everybody can have the website and they could click on it from their smartphones or their computer. Okay, Lila, I'll let you go ahead.
Hi, everyone. So this is the mobility evaluation. So as you can see on the screen, it asks for the total number of residents in your care home or foster home. So if you have more than one resident, please mark the box next to the years at the top. So start with the resident that you admitted first in your home, and then you're gonna go down the line and answer the question. Now, if your first resident is unable to walk or stand without full assistance, let's say they can't get out of bed, they're not, they can't walk on their own. So, um, if you're gonna answer yes or no. If you answer yes, then you won't have to go through the questions. If you answer no, then you're gonna answer those questions from A, B, C, D. And then you're gonna repeat with your resident number two. Again, it would be the second resident that you admitted in your home. And then if you have three, you're gonna do the same thing with your third resident. Are there any questions about the mobility evaluation? Feel free to type in the chat as well if you don't, if you're too shy to come off mute. Okay, now we're gonna go on to the tug tests. The next slide, John. I'm curious, how many of you are doing the tug test? Have you done it, or are you doing it, or are you having any challenges doing it? Please feel free to share. You can either email or put your question in the chat if you're too shy to come off mute.
The timed up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
Any questions about the tug test? You saw the timer on the video. You don't have to have a fancy timer like that. You could actually use your iPhone. All right, so in order for you to receive your certificate of attendance or the CME for those licensed attendees or caregivers, please make sure that you complete the evaluation at the end of this session. And please ensure that we have your correct email address and your names. And you're going to complete, if you are attending as a group, you're going to have to complete one evaluation for each attendee. So one person cannot complete for the whole group of attendees. Thank you so much for your service and for attending this session this morning. And I want to say thank you, Mr. Higa, for the presentation. Very informative, and learn some things today. Thank you for everyone's time.
Thank you everybody. We appreciate your attendance.
Glenn, I want to share some of the comments in the chat for you. We have Marianne who is sharing that. Thank you, Glenn, for sharing your personal experiences. This was truly brave of you. Glenn, we are very inspired by your journey. We learned a lot today, and we all hope to live a purpose-driven life like you and do good in the community and help others. I know from today's training, we are going to have people coming to your offices at Liliha and going to your website and maybe joining the support group. So this has been a fantastic education for everyone because we have many clients in care homes and foster homes who have Parkinson's disease. So this training today was very, very helpful, Glenn. Mahalo for your time. Mahalo for your kindness on sharing your knowledge and wisdom with all of us.
Thank you, Dr. Fernandez. Thank you, everybody. Appreciate your time. Thank you.